So this has been a great meeting so far, and I really appreciate the opportunity to talk to you today. I'll be talking about targeting cancer stem cells for a durable response. So really, this slide sets up the problem, and I think we'll come back to this in various ways during the talk. So basically, tumors, I think we now accept that tumors are heterogeneous. Not all the cells are the same in the tumor. And various current treatments, especially cytotoxic agents, can often be very effective at debulking the tumor. And that's illustrated in this slide by knocking out the cells shown in blue, for example. But the problem is that certain cells can remain, which we call cancer stem cells, and they have two properties that are unfortunate. One is that, as implied, they're resistant to most current treatments. Even radiation therapy, they can often be resistant. But the second unfortunate property is that they have the ability, if they survive, to regenerate the tumor in its original heterogeneity. So I recently heard an analogy to the queen bee in a hive. If you want to kill a beehive and you kill a lot of the bees, but you leave the queen bee could regenerate the hive either locally, or it can go to the other side of your yard and regenerate a hive. And you won't just get a bunch of queen bees, you'll get drones and worker bees and all of the diverse aspects of the hive. So the way that we've targeted, so I hope I didn't mix metaphors there. So the way that we've dealt with this problem is to develop compounds that preferentially target these cancer stem cells. And the concept is that if you combine compounds targeting the cancer stem cells with some of the standard agents that target the bulk tumor, now you have a better chance of getting complete reduction of the tumor, including elimination of the cancer stem cells. And the eventual hope would be that you get a more durable clinical response. So what's the evidence that cancer stem cells actually exist and are increased by chemotherapy? This is a paper from Jenny Chang's lab in Houston. And what they found is looking at breast cancer, either triple-negative breast cancer on the left or ER-positive breast cancer, treating with various chemotherapies, and looking at the proportion of cancer stem cells in the tumor after initiation of treatment, you can see that the proportion of cancer stem cells go up in response to chemotherapy. And in these graphs, they measured CD44 high, CD24 low cells, but you can also look at other assays that I'll mention throughout the talk, such as a tumor sphere assay that they use that looks in vitro at cancer stem cell self-renewal. But the bottom line is that the proportion of cancer stem cells go up in response to chemotherapy, largely because these cells are more resistant to chemotherapy. So why does that matter? This is an interesting recent paper from a Japanese group. And what they found is, we know that generally if you do breast cancer surgery and you look at the lymph nodes and there's no tumor burden in the lymph nodes, you feel pretty good about that there's not metastatic disease. And that's what this top graph shows, that overall survival is quite good if there's no metastasis in the lymph nodes. But the surprising thing here is that if you look at the situation where you do have cancer in the lymph nodes, what they found is that if you have cancer in the lymph nodes that has ALDH1 positive cells, which is one of the markers of cancer stem cells in the lymph nodes predict for poor prognosis in terms of overall survival. But interestingly, if you have cancer in the lymph nodes but no ALDH1 positive cells, you actually do quite well, almost as well as if there were no cancer in the lymph nodes at all. So what this is saying is that it's really the cancer stem cells in the lymph nodes that are ultimately predicting for disease progression and poor prognosis. So we set out with technology initially developed in the labs of Bob Weinberg and Eric Lander. And we're looking for, using a proliferation assay to look at cancer stem cells on the one hand and bulk tumor cells on the other hand, and just looking for selectivity for the cancer stem cells. And some agents are relatively non-selective that we found between the two populations. Many agents are selective for the non-cancer stem cells, and most of the cytotoxic agents would wind up on the left side. But quite rare are the agents that preferentially target the cancer stem cells with better potency than you see against the bulk tumor. And between us and the Broad Institute, we screened over 300,000 compounds and came to focus on a few key pathways that we identified pharmacologically. So one of those pathways is the focal adhesion kinase pathway, FAK. A second is PI3 kinase mTOR, and the third is the Wnt beta-catenin pathway. And we now have two FAK inhibitors that we're developing, both now in clinical trials. And the idea is if you block the FAK pathway, you can block cancer stem cell survival and self-renewal. We also have an interesting PI3 kinase mTOR inhibitor, VS5584, that we're developing also for the same endpoint. And Dejan previously introduced this pathway and also introduced with the Elkabitz paper that he talked about toward the end, the idea that in some cases it's desirable to hit the pathway broadly, to hit PI3 kinase and TORC1 and TORC2. And I'll come back to that toward the end of the talk. And then we have a discovery collaboration with ASI looking at novel inhibitors of the Wnt beta-catenin pathway, and we think this is also a very important pathway in regulating cancer stem cell biology. So let's go specifically to focal adhesion kinase. And many of you probably know that this is a signaling molecule that's downstream of integrins. Integrins engage extracellular matrix, fibronectin, vitronectin, et cetera, to give survival signals and proliferation signals to the tumor cells. So FAK is a non-receptor tyrosine kinase that regulates tumor cell proliferation, survival, and migration. But some interesting findings from the literature regarding cancer stem cells. So I think cancer stem cells are better described as tumor-initiating cells, and that's the functional definition that I prefer to use. And this group from University of Michigan did a conditional knockout of FAK on one side, and they got less tumor growth in the initial mouse with that knockout. But interestingly, really the gold standard for tumor-initiating capability is to take cells after treatment or after whatever the perturbation is, go into a second immunocompromised mouse and do limiting dilution and see whether you can initiate new tumors. So if you take cells from the wild-type FAK side of the mouse, you put just 5,000 ALDH positive cells in, you get initiation of new tumors very well. If you take cells from the FAK knockout side of the mouse and put in the same 5,000 ALDH positive cells, you don't get tumor initiation, showing that FAK is important for tumor initiation or cancer stem cell capability. Bob Weinberg's lab recently published a paper where they were interested in the process of EMT, epithelial mesenchymal transition, and how do you get from that to tumor initiating capability or cancer stem cells. And without going into a lot of detail, what they found is to get from EMT to macrometastasis in the lung in this case, so tumor initiation, a critical signaling pathway was FAK. I mean, if you knock down FAK, you don't get there. So numerous biological proofs of concept for FAK, but we came to it pharmacologically. So here's one of our FAK inhibitors, VS4718, as an example. And these are some of the numerous assays that we use. I think it's important to define cancer stem cells by numerous orthogonal assays, and it's also important to validate each assay where you, for example, look at ALDH positive cells, aldofluor positive, which is an enzyme assay looking at that. You can take those cells, put them into mice, and show that a small number of cells is sufficient to generate a tumor. That's proof of concept that these are tumor-initiating cells. So for these assays, we generally use a lot of the drug resistance properties that cancer stem cells harbor. So for example, ALDH is a detoxifying enzyme. This aldofluor assay looks at ALDH activity, so you're specifically looking at the cancer stem cell population. You can see that the FAK inhibitor gives you nanomolar inhibition of that aldofluor positive population. If you knock out FAK with siRNA, you also knock down the aldofluor positive cells as a percent of the total population. Another property of cancer stem cells is that they can pump out cytotoxic dyes. So a surrogate for that is to use, cytotoxic drugs. So a surrogate for that is to use a Herx dye and look at the side population, the cells that can exclude that dye, compared to the main population which actively takes up and retains the dye. So the cancer stem cells here being defined as the side population, you can see that the FAK inhibitor can eliminate that population. And then this is a functional assay. Tumor sphere formation is a self-renewal assay that we use. And you can see that FAK inhibitor is very effective there as well. How about in vivo? So we can take mice bearing tumors, in this case a triple negative breast cancer xenograft, and we treat either vehicle control or with the FAK inhibitor. And we can look at the tumors for ALDH immunofluorescence. You can see cancer stem cells here in a representative field. They're decreased in the FAK-treated tumors, FAK inhibitor-treated tumors. And to quantify that, you can dissociate the viable cells and ask certain questions in the absence of subsequent drugs. So the drug was only seen in vivo in the initial treatment, but if you look at the cells that result, you can see that there are fewer aldofluor positive cells, one marker of cancer stem cells, much less ability to form these tumor spheres, which is a self-renewal assay again. And if you put those cells into other immunodeficient mice, about 10-fold reduction in the ability of the FAK inhibitor-treated tumor-derived cells to form tumors in secondary mice. So, okay, so we've established that FAK inhibitors can preferentially target cancer stem cells, so where do we go with that? And for a variety of reasons shown here, we were very interested in ovarian cancer. So the reasons, so the presence of cancer stem cells in ovarian cancer has been shown to correlate with poor survival. High tumor, these are data from Anil Sood and MD Anderson, high tumor FAK and notably phosphofAK, so looking at the autophosphorylation site. High expression of FAK and phosphofAK correlates with poor survival in ovarian cancer patients. In our initial phase 1 study with the more advanced FAK inhibitor, VS6063, there was some initial clinical activity seen. So out of 8 ovarian cancer patients, 4 of them had stable disease and 3 of them had stable disease for at least 6 months as single agent. And finally, some interesting data that were just published very recently. VS6063 can resensitize drug-resistant ovarian xenograft models to Paclitaxel. So here's an ovarian xenograft model treated with Paclitaxel or 6063. Both have some effect, but you have more effect when you combine them. But interestingly, this is a model, another ovarian xenograft, but it was selected for resistance to Paclitaxel. So you can see when you grow it, sure enough, it's resistant to Paclitaxel alone. Some effect of VS6063, but when you combine the two, the FAK inhibitor is increasing the sensitivity to Paclitaxel. So for these various reasons, we were interested in pursuing ovarian cancer. And I'll come back to this initial slide. So I talked to you about the solution generically, that you would combine an agent targeting the bulk tumor cells with an agent preferentially targeting the cancer stem cells for a more durable clinical response. Now we can specifically think in ovarian cancer about Paclitaxel targeting the bulk and the FAK inhibitor targeting the cancer stem cells. And here's an interesting model that was done in the lab where you're looking specifically at tumor-initiating capability. So what was done here is in vitro treatment of a human ovarian cancer cell line with various treatments. So you can treat control treatment, treatment with Paclitaxel, treatment of FAK inhibitor, or treatment with a combination of the two. And after the treatment, the cells were allowed to recover for 4 days, and then just 1,000 cells were then implanted in mice to see if they retain the ability to initiate tumors, the cancer stem cell phenotype. So you can see here the control-treated formed tumors just fine. Paclitaxel treatment didn't reduce the ability to form tumors, so tumor-initiating cells are still there. The FAK-treated tumor cells are reduced in their ability to form tumors, but interestingly, when you combine the FAK inhibitor with Paclitaxel, then you didn't get formation of new tumors. And looking across a number of mice treated in the same way, you can see that Paclitaxel might slightly delay, but ultimately you get to the same end. The FAK inhibitor alone decreases initiation of new tumors. And in no case, when we combine the FAK inhibitor and Paclitaxel, do we see initiation of new tumors, indicating that the tumor-initiating cells or cancer stem cells are essentially gone or inactive. So we've initiated a combination study in ovarian cancer patients with the FAK inhibitor 6063 in combination with Paclitaxel. And the first finding was that these are well tolerated as a combination. So this is the first time a FAK inhibitor has been combined with anything else in the clinic. So that's promising. And I'll just take you to one patient, actually from the initial 6 patients in the first phase of the study. And so she was a 59-year-old female diagnosed in January 2012 with stage 4 ovarian cancer. And she initially responded to carboplatin paclitaxel, which is the typical initial adjuvant therapy after surgery. She responded for about 7 months, but then after completing the course, relapsed 3 months later. She didn't do well with doxorubicin-based therapy in terms of toxicity. But when she came to us, she had rising CA-125, as shown here. After beginning treatment with paclitaxel plus the FAK inhibitor, you see reduction of CA-125 into the normal range. And a complete response was confirmed by MRI, and now it's been, I think, 7 months, and she still has a complete response. So it's early days, but it looks promising. So that was ovarian cancer. Leaving cancer stem cells for a moment, we've also taken kind of standard translational research approaches to think where would the FAK inhibitor best be deployed. So in this experiment, we use the FAK inhibitor with a series of different types of human cancer cells where they're grown in 3D matrigel culture to resemble the tumor more closely than just growing on plastic. And what you find is there's about 100-fold spread in the sensitivity of these different cell lines to the FAK inhibitor, from 100 nanomolar to 10 micromolar potency in knocking out proliferation of these cells. As we looked at the data closely, we found that those that are most sensitive, the majority of them actually had low Merlin. So Merlin is a tumor suppressor encoded by the NF2 tumor suppressor gene. And as we learned more about Merlin, we looked for where Merlin loss is most prevalent, and that took us to mesothelioma, which is a tumor of the lining of the lung. It's typically occurs 30, 35 years after asbestos exposure. And so about 50% of mesothelioma patients have a mutation or deletion of NF2, giving rise to loss of the Merlin tumor suppressor protein. So here's a panel of mesothelioma cell lines, again in 3D matrigel culture, with the FAK inhibitor. And what you can see is that all of these lines that are more sensitive are the ones that are lacking Merlin expression, whereas those that are somewhat sensitive but less so in terms of potency have wild-type Merlin expression. So this gave rise to the idea that maybe we can stratify or select around Merlin-low mesothelioma patients and expect to see good efficacy with our FAK inhibitors. And here's a xenograft study, an orthotopic model, a Merlin-low mesothelioma, and you can see that the FAK inhibitor was extremely effective in preventing or blocking tumor growth, and that correlated with blocking the autophosphorylation of FAK, or the activation state of FAK, in the tumors in that model. And so as we completed that work, we were gratified to see that that GSK at the 2012 EORTC meeting had clinical proof of concept early on for the same concept. That if you look at mesothelioma patients in general, they had 29 in their phase 1 study expansion phase. They saw that there is some increase in progression-free survival relative to historical control. But what was really intriguing is if you break out, there were 23 patients that had evaluable Merlin status. And if you look specifically at the Merlin negative patients on that study, they had even a greater benefit in terms of longer progression-free survival. So that seemed to clinically validate some of the early preclinical findings that we had. So let's come back to cancer stem cells now. And unfortunately, in some cancers, they haven't been as well studied. So there was a publication that had showed that cancer stem cells are expressed in mesothelioma patient samples, but we began to look at what conventional chemotherapies do. So in mesothelioma, pemetrexed is the only approved agent. Typical first-line therapy is pemetrexed with a platinum agent. And in second line, although there's nothing approved, gemcitabine and vinorelbine are common drugs to be used. And what you can see is that in Merlin-negative mesothelioma cell lines, all of these cytotoxic agents increase the proportion of cancer stem cells, as I mentioned before, with other cytotoxic agents and other indications. Both FAK inhibitors, 4718 and 6063, decrease the proportion of cancer stem cells. And interestingly, you can if you treat, for example, with gemcitabine, and you can see an increase in cancer stem cells, but if you add the FAK inhibitor to that mix, you can block that increase in cancer stem cells with gemcitabine. Coming back to the mesothelioma orthotopic model that we ran, if we look at ALDH positive cells as a measure of cancer stem cells, you can see a couple of representative fields where we can see just a few cancer stem cells within the tumors, the mesothelioma tumors. But in the FAK inhibitor treated tumors, we saw absence of those ALDH positive cancer stem cells. And here's quantitation across a number of tumors and fields, and you can see a decrease in the percentage of aldolfluor positive cancer stem cells. So now I wanted to come back to a variation on this theme. So before I talk to you about concurrently treating with an agent targeting the bulk tumor and an agent targeting the cancer stem cells, but I think another interesting concept would be a maintenance concept. So you could picture treating with first-line therapy to debulk the tumor. You're aware that you're leaving the cancer stem cells, but then you could treat with a cancer stem cell preferring drug and try to maintain the patient, prevent outgrowth of the tumor, and hopefully, again, get to a more durable response. And that's what we're doing in terms of mesothelioma. So again, the standard therapy is pemetrexed plus a platinum agent. We can come in a maintenance setting then with a FAK inhibitor and see whether we can get to a more durable response once the disease has been controlled by first-line therapy. So here we've modeled that preclinically, where we treat, so this is a patient-derived xenograft. It's a Merlin-low mesothelioma. Patient-derived xenografts are thought to be more representative of human cancer than our cell lines that have been passaged for years on plastic. And you can see that without treatment, you get growth of the tumor. If you treat with cisplatin plus pemetrexed for 14 days, you control the tumor quite well. But once you stop treatment, and you typically have to do that in the clinic due to tolerability issues, especially with cisplatin, then the tumor grows out essentially in parallel to the control. Whereas if at the time of stopping the cisplatin pemetrexed treatment, if you start to treat with a FAK inhibitor, you can get a more durable response. You can prevent outgrowth of the tumor. So as a clinical strategy, we've started a trial where looking at mesothelioma with the FAK inhibitor via 6063. And typical treatment of mesothelioma before the FAK inhibitor is considered is shown here. So as I mentioned, first line is typically cisplatin plus pemetrexed. The median progression-free survival is 5.7 months. Then typically, one can't continue that treatment beyond a certain point because of tolerability issues. And once the tumor progresses, there's really no approved therapy, and it's really just dealer's choice, but there's not a lot of hope at that point. So what we did is we thought again that standard of care agents during the first line therapy, we think from our preclinical data are going to be increasing the cancer stem cells. So we can treat now in the maintenance setting compared to placebo, and the hope is that by targeting the cancer stem cells will delay recurrence. So the trial is a worldwide trial that was initiated just last month, stratified based on Merlin protein expression being measured by immunohistochemistry, and the key endpoints are progression-free survival, overall survival, and quality of life, such as breathing difficulty, et cetera. So the other pathway that we came to in the initial screen is the PI3 kinase mTOR pathway. And I think we all appreciate that this is an important pathway in cancer, but what's less appreciated is what we stumbled upon, which is a preferential effect of PI3 kinase mTOR blockade on cancer stem cells, and I'll take you through that. So the agent, and I think Dejan also mentioned a paper where dual inhibition of PI3 kinase and mTOR could give better efficacy or prevent acquired resistance relative to PI3 kinase alone. So this agent, I think, has quite a favorable profile, unlike the alpha selective agents that he talked about. It's pan-PI3 kinase, all the PI3 kinase isoforms involved in human cancer, but also about 3 nanomolar biochemical potency also against mTOR kinase, which is, so therefore TORC1 and TORC2. And this is an agent that we plan to initiate phase 1 by the end of this year. So again, with this initial assay that came from Bob Weinberg and Eric Lander, the initial observation was looking at proliferation of the cancer stem cells compared to the non-cancer stem cells. We saw more potency in targeting the cancer stem cells with this PI3 kinase mTOR inhibitor. Using the other assays I already described to you, we can eliminate the side population cancer stem cells. We can eliminate, or we can decrease the aldolor positive cancer stem cells. And we always run some of the cytotoxics as control. So you can see that in direct contrast, paclitaxel increases the percentage of cancer stem cells as measured in this assay. So interestingly, if you look at aldolor positive cells or aldolor negative cells as cancer stem cells and bulk tumor cells, here we saw about a 30-fold preference, more potency against the cancer stem cells. And similarly, when we looked at apoptosis, we saw that we see apoptosis induced in the cancer stem cells and not the non-cancer stem cells. So what this brings to mind, there have been issues with tolerability and therapeutic window with PI3 kinase mTOR inhibitors, but one could potentially, if you wanted to go into a maintenance setting and suppress the cancer stem cells from regrowing the tumor burden, you could consider treating at a lower dose, a lower plasma exposure, because it might take less drug on board to suppress the cancer stem cells than to suppress the bulk tumor, and that might be sufficient in a maintenance setting. So I think it's an interesting concept. I think Dijon also mentioned that everolimus was quite successful in the Bolero-2 trial in combination with an aromatase inhibitor. And so we compared what's the effect of everolimus on cancer stem cells in vivo compared to the PI3 kinase mTOR dual inhibitor. So everolimus, a rapamycin analog, only hits TORC1. And what you can see, it was the same setting where we took mice-bearing tumors, treat with control or compound, and then ultimately dissociate the viable cells and query them for cancer stem cell or tumor-initiating capability. And you can see that everolimus in each case did not reduce cancer stem cells in these various assays. If anything, it might have increased the tumor-initiating capability, certainly didn't decrease it. But if you look at the dual PI3 kinase mTOR inhibitor, 5584 now, you can see that by all measures, a really strong inhibition of cancer stem cells by markers, as well as a strong inhibition of tumor-initiating capability. We also heard about mutations in PI3 kinase alpha or PTEN loss as being predictive in some cases of sensitivity to PI3 kinase mTOR inhibitors. I think small cell lung cancer, looking at a panel of cell lines, we see that those that have activating pathway mutations are somewhat more sensitive than those that don't. But small cell lung cancer is an interesting place to think about cancer stem cells because it's very responsive to first-line therapy. But then within the space of about a year, the tumor comes back with a vengeance. So it's a place to think about, again, a maintenance kind of approach where you could suppress the tumor burden and then maintain on a cancer stem cell suppressing agent, and maybe you could greatly extend survival. And that's what we've tried to model here. So you can see that here's a small cell lung cancer xenograft model, grows very rapidly. If you treat with cisplatin for 2 weeks, you control the tumor very well, but when you stop treatment, the tumor comes back rapidly. But if you treat with cisplatin and you also use the PI3 kinase mTOR inhibitor, you can get a much more durable response. So one more idea around maintenance, again, as I just said, is you could picture treating with cisplatin and etoposide to knock out the blue cells, the bulk tumor, and then maintaining on VS5584, potentially at lower doses, so not toxic doses of inhibitors of this pathway, but sufficient to hit the cancer stem cells. So we're developing a number of agents targeting cancer stem cells, and it's really exciting times for this field now because we're just starting to play out our compounds. I think there's some antibodies now targeting cancer stem cell targets from Alchemed, and we're just now getting a look at what's going to happen clinically. So you can see we're developing 2 FAK inhibitors, 6063, I mentioned the mesothelioma trial, which is the sequential maintenance kind of approach. And I mentioned the ovarian trial, which is more of a concurrent approach with Paclitaxel. I didn't have time to go into our lung trial, which also initiated. And we're also doing a phase 1 trial in Japan with the FAK inhibitor because asbestos was just banned in 2006 in Japan. There's been a large rise in the incidence of mesothelioma, which has continued. So we're looking to see if we can help Japanese mesothelioma patients with the drug as well. VS4718, a second generation FAK inhibitor, just started phase 1 as well in solid tumors. And I mentioned VS5584, the PI3 kinase mTOR inhibitor, which we expect to be in phase 1 by the end of the year. And this is a discovery collaboration. So with that, I'll conclude. So we think it's important to target both the bulk tumor and the cancer stem cells for durable anti-cancer responses. Virtually every cytotoxic agent we've looked at increases the proportion of cancer stem cells in vitro and in vivo. And as I mentioned at the beginning, that's been seen clinically as well. Inhibitors of FAK, VS6063 or VS4718, and inhibitors of PI3 kinase mTOR, such as VS5584, preferentially target cancer stem cells in multiple cellular and animal models. Agents targeting bulk tumors and cancer stem cells can be combined concurrently, or alternatively, you could combine them sequentially. And we now have several clinical trials in progress to test the hypothesis in the clinic. So with that, I'd like to just thank contributors and collaborators, the Veristem research and biomarker team, and a number of collaborators. Thank you for your attention. I'll take any questions.
All right. So very fascinating. Have you tried to combine your FAK inhibitor with radiation therapy? While stem cells do limit the curative potential of radiation, if you could eliminate a few more by combining it with that inhibitor, that would be very exciting.
It really makes sense. We haven't gone there at all yet, but it makes a lot of sense. Yes? Right behind.
What do you know about toxicity against normal stem cells?
I think rather than looking in vitro, for example, at normal stem cells, we've tended to look at the tox data. So the FAK inhibitors have been extremely well tolerated, both in toxicology studies in rodents and monkeys, but also now in phase 1 trials. So I think that we haven't seen anything striking. You might expect GI toxicity, for example, inhibiting cancer stem cells, and we've seen some GI tox, but it's not clear that it's associated with normal stem cells. Yes? Microphone down here, if you could. Okay.
I'm just concerned about what you said about reducing the dose to non-toxic levels. You don't have really good readout clinically on a cytotoxic or a deleterious effect on stem cells. In other words, you can't quantitate the effect very easily. So by reducing the dose, you may compromise the efficacy. So I would think that you'd want to use the drug at the best, a dose close to the maximum tolerated.
Yeah, I actually strongly agree. I think there's that opportunity, there's that logic, but I'm of the belief as well that targeted agents should be used toward MTD for maximum chance.
And these
success.
patients are not cured, so you're not, toxicity is okay as long as you're not compromising cure, but these patients are not cured by conventional therapy, so I wouldn't worry.
Agree. Thank you.